kgs alone, if they are around 100 kgs, the excess body weight 50 kgs is a burden for them. And if we ask them to go for any gym or any yoga, if they don't like, they don't follow it for long term. So they should have the interest of their physical activity. And it depends on the intensities of workout also. Sir, everyone says that, yeah, I'm going for walking even though I'm not losing weight. Then we need to know that how much of calories they burn in that walking. If it is going to be a fast, yes, the intensities matters in that walking also, which burns better calories in slow walking or in jogging also. And the time management, sir, I don't get even single time because my business is busy, my work is busy. I get at least half an hour. In half an hour, I just go for just walking alone or jogging alone. In half an hour, you need to spend more time to burn more calories. So these are the things which we need to assess them before telling that, sir, this is what exercise you need to do. And always they will say, sir, I have bought a treadmill or some Orbitrek in my home. It is there, but I am not using it. But when it comes to the home scenarios, for even for housewives, this treadmill or Orbitrek in their home is going to be, after some point of time, it's going to be a boring scenario. That treadmill which has been bought in a new, first day it will be kept in front of the TV or some in front of the wall. When after 2 to 3 years, it just goes in a corner of the house, only dirt clothes will be on that clothes. So every day we should ask them to change their environment according to their liking, so that every day is going to be a new day, so they will have their interest on their physical activity. So when it comes to not only diet and physical activity, and yes, sleep is also more important. When it comes to sleep, it has to be 6 to 8 hours of sleep, reduce the screen time, add more fiber intake before sleep, be relaxed. And when your sleep is getting disturbed, your day cycle is getting disturbed, promote stress, no hunger, not active, and no physical activity even. So this again, they won't able to do any physical activity. So sleep is an important factor. More than that, the sleep apnea. What we always know about the sleep apnea is that when a person is about more of central obesity, it puts a pressure on the diaphragm so that the lung cavity gets decreased. So patient doesn't get enough oxygen supply, so they have a sleep apneic pattern, so they don't get into the circadian rhythm of sleep. So next day morning they will feel very tired and lethargic. There won't be any physical activity, first thing. And this affects more of obese people. So excess body weight plus sleep apnea, they don't lose weight even 1% of the excess body weight. So they will get, over the age goes off, they will be more and more obese. Then again the metabolic syndrome complication occurs. So sleep apnea, if you don't treat sleep apnea, even mild to moderate sleep apnea, the patient is not even going to get even lose weight. So in this team, always we need a pulmonologist also to evaluate what type of sleep pattern they are having. So if you treat a sleep apnea, yes, the patient will lose weight without even surgical management when there is a mild to moderate of sleep apnea. So when it comes to psychological stress, when there is a poor sleep pattern, increased hunger hormones, weight gain and sleep apnea. So again there won't be any sleep. The next day again there will be, patient will be psychologically stressed or physically stressed. The more and more the work they do, it will make them stress. So one fine day they will get very frustrated because of my weight, I am not able to do anything. And moreover, even patients who check weight daily, they will also will have a psychological stress. The first day they used to go to get off some weight, they used to come and check weight on the day morning itself. That itself is going to promote stress. See, even in star hotels, yes, might be in this star hotel also, if you go into the hotel rooms, yes, there will be a weight machine to check daily. So that also will promote a stress again. As per right now, as sir said, yes, the risk of obesity like hypertension, diabetes, dyslipidemia, cancer, osteoarthritis, and again gallstones and fatty liver, skin infections, sleep apnea, and severe sleep apnea may even death very easily more than cardiac arrest, and low back pain, impotence, infertility and menstrual disturbance, PCOD in females, psychosocial depression, suicidal tendencies, some malignancies like colorectal, gallbladder cancer, breast and endometrial cancer, cervical cancer, iatrogenia. The more sleep apneic patients are more prone for accidents. What is common between diabetes and obesity? Both are lifestyle related diseases. Diabetes is carbohydrates and calories problem. Obesity is calories and a fat problem. So what happens when obese people are diabetes is when people are obese, which causes insulin resistance. When it causes insulin resistance, see, when a person takes more food intake, when the energy expenditure is very low, it causes obesity, which causes insulin resistance. And the insulin resistance causes reduced neuronal insulin leptin action. So again, it makes the patients to have more craving. So again, the food intake will be more. So this causes to type 2 diabetes. So as we all know that, yes, when it comes to type 2 diabetes in an obese or a normal individual or overweight individual, yes, it has to be like physical activity, diet and medical management. So this is how we all know that this is how the management should be done. And when people are obese or with diabetes, this is what happens in hormonal changes in the stomach. See, when a person's stomach is empty, this is a normal physiological happens in a person's body. When a person's stomach is empty, there will be more of ghrelin secretion, so there will be increased appetite. When a stomach is full, the ghrelin secretion will go down and appetite will decreases. But when a person's are morbidly obese, like BMI is more than 30, 35. So when the more than 35, so what happens is the ghrelin secretion will be just secreting more, so that so when the ghrelin secretion secreting more, there will be more appetite and patients will be having more of food craving. So this is the hormonal response in a physiological and a pathological one. See, and again, when there is a more of adipose when there is a more of adipose tissue percentage will be there will be increased food intake. It is because of the leptin hormones which is secreted from the duodenum. See, when it comes to lifelong management for obesity, is always diet, physical activity, medicine or surgery or both. And again, for the prevention, again it's diet and physical activity alone. See, when it comes to any surgical management, like in the past, obesity was seen as a weakness or a failure of an individual. Diet and physical exercise were prescribed after treatment. Weight loss surgery was viewed as dangerous and extreme. Now in the present, obesity is considered as a disease and cause for many serious health conditions. Surgery has gained acceptance and the only proven method to treat this disease. When it comes to surgical treatment, diet, exercise, anaerotic drugs and behavioral modifications are not effective therapies in a morbidly obese patients. Only proven methods of achieving long-term weight control does not involve removal of fat. It is not a cosmetic procedure. Surgery is adjunctive, not a curative. See, not only to reduce the weight, but more importantly to improve the associated comorbidities also. See, when it comes to surgical or medical management, this is how we assess the patient, that the factors affecting should be like, we should assess the age, body mass index, presence and absence of comorbidities, patient preferences and compliance, and surgeon's experiences. The surgery of the choice is often subjective and decision is made about the risk-benefit ratio. See, these are different types of surgeries. See, all these surgeries are designed as restrictive, malabsorptive and combined, both restrictive and combined restrictive and malabsorptive procedures. In the nowadays all these procedures are not done under open procedures, all by laparoscopic. Yes, 100% by laparoscopic, because when we do open procedures in a morbidly obese patient, the complication rate again increases, like DVT, ERDS and other procedures. See, because of the laparoscopic, there won't be any pain, no scar, so there will be painless procedure. The patient, after 5 to 6 hours after surgery, we will be able to mobilize the patient in a day, and we will be discharging in a day of 24 hours to 48 hours. See, this is a restrictive procedure called adjustable gastric band. So in this band, in the adjustable gastric band, so we will just put a band over the fundus of the stomach. So this restricts the amount of food what they have. This is a temporary procedure. So this again as an indication, we will just even operate with a BMI of we will operate with a BMI of more than 70 with severe comorbidities, like for anesthesia complication, we just take 15 minutes to half an hour to do this procedure. And after 1.5 years, 2 years, when the patient loses weight, the complication of anesthesia reduces, we do a definitive procedure then. This is a pure malabsorptive procedure where the stomach pouch will be reduced like 50% and the small intestine will be diverted, and the ileum will be joined with the duodenum, the fourth part of the duodenum. So this creates nearly 50% of the small malabsorption, and 50% of the restriction of the food will happen. This procedure is called அது வீடியோ ப்ளே பண்ணுங்க. அங்கிருந்தா ப்ளே பண்ண முடியும்னு நினைக்கிறேன். இது வீடியோ ப்ளே பண்ண வேண்டியது. See, this procedure is called sleeve gastrectomy. I am just elaborating this one in an animation video so that you will have a better understanding. We all know that this is going to be a laparoscopy. This is what the laparoscopic surgery is. Minute puncture holes in the abdomen. கொஞ்சம் வேணா ஃபாஸ்ட் ஃபார்வர்ட் பண்ணிடலாங்க. So in this surgery what we are going to do is we restrict the stomach pouch, like 70 to 80% of the greater curvature of the stomach will be removed. So this causes restriction of food. As I told you about some hormones called ghrelin, yes, it is a gut hormones. The gut hormones of ghrelin will be secreted from the fundus of the stomach. So in this surgery, we remove nearly 99% of the fundus. So whatever the food restriction happens will be there, and when the fat percentage goes down, the ghrelin hormone also will be secreted as per normal according to his height. So this is called sleeve gastrectomy. Sleeve gastrectomy was coined in the name of shirt sleeve, which is going to be tightened. So this is a sleeve, and nowadays we started putting a sleeve, a band over the sleeve, because this is called banded sleeve gastrectomy. See, after a span of 5 to 10 years, do we think this stomach will go? As we all know that stomach doesn't grow, but it has a capacity to expand. It is not because that it is stretchable. After 5 to 10 years, because the OG junction is intact and pylorus junction is intact, there will be intraluminal pressure will be more, so that after 5 to 10 years, after a span of period, it has a capacity to expand. So after 5 to 10 years, the percentage of amount will be increased, like not like 100% what they eat before. It like 10-20% after surgery. It will be 20 and 20% increase after surgery. So the patient, if the patient doesn't want to increase the capacity of the stomach, we just put a band to restrict the expansion also. This is called banded sleeve gastrectomy video. This is a combined procedure like restriction and malabsorptive procedure. This is used to treat like obese people with diabetes, with chronic diabetes of more than 5 to 10 years. These are the indications should be there to each surgery. This one surgery is not given to all. Each procedure has some indication which procedures to be given to that each individual. In this procedure, again the pouch will be restricted like 100 to 150 ml capacity pouch. Again, the fundus will be separated and kept in the stomach, in the abdominal cavity. The jejunum will be divided into two parts. The first, the distal part of the jejunum, we call it as an alimentary limb, and will be joined to the stomach pouch. And the resected part from the proximal end of the jejunum will be joined to this part of the jejunum. So the food directly passes to the alimentary limb, and the bile and the pancreatic juices and the mucus secretion from the remnant stomach side will be joined over here. This is called gastric bypass procedure or Roux-en-Y gastric bypass procedure. So again, this procedure again has been coined, say after again 5 to 10 years, this also has a capacity to expand, and there is a chances of putting on weight. So to avoid it, we started putting a band during the first surgery itself. This also has an indication. It cannot be the procedure, the band cannot be applied to all. So this is Roux-en-Y gastric bypass. This is a surgical video. What we do it laparoscopically again. This procedure is called mini gastric bypass. Video please. Excuse me, video please. See, nowadays we use all advanced vessel, this advanced vessel sealing technology more than a bipolar. We call it as harmonic or NSeal. So the blood loss is very minimal, and we can accurately catch even single bleeding also. So this is the, see above you can see the liver. We operate in the OG junction right now. Above is the liver. This is how the fatty liver will be. It will be very huge and it will be very hanging. It will be very difficult to. We are just making a path to make the jejunum and just anastomosis with the jejunum, with the stomach pouch. Because this is the visceral fat or the omentum which is inside. In morbidly obese patient, the omentum thickness will be very thick. So this is what it causes central obesity and metabolic syndrome. To patients who need to lose weight and control the diabetes, the first thing, the central obesity or the visceral fat should go down. It is not about the subcutaneous fat which has to go down. So we join the jejunum to the stomach pouch. Now we are restricting the food by restricting the stomach pouch, creating a new stomach pouch. The food restriction will be there. This is the stomach. This is, we call it as a stapler technology. What we do is, we put a stapler at the incisor angularis of the stomach. We divide from that area. So this is the small stomach pouch we are going to create. The other rest of the stomach will be in the abdomen only in these surgeries. So this is the pouch. This much alone the patient can eat. But after 5 to 10 years, this also has a tendency to expand. But we are doing the jejunum to bypass. One thing is restriction of food by reducing the size of the stomach. And when we are bypassing the small intestine, for one part of the small intestine, it doesn't go. That we measure the small intestine loop length like 100, 150 centimeters, 175 centimeters. See, as we all know that the small intestine length is like 600 to 800 centimeters, person to person it changes. But we altogether totally measure the total small bowel length and we bypass at least 5 to 8% of the small bowel intestine alone. So we are not creating like 100% of malabsorption. We are just creating 5 to 8% of the malabsorption as per individual. That is the new stomach pouch, and this jejunum will be joined over here. See, as you see, there won't be any sutures in this surgery. We create everything by stapler technology. This anastomosis seals and it closes all the wounds. Nowadays these technologies are being converted by robotic technologies even. So the percentage of all these procedures are nearly, because of these better instruments and better technologies, we are able to do it much safer. And the complication rates are very much negligible and nil even. So we overlay with this again, it's advanced suturing technology. We call this as endo stitch. It's like a tailoring system. So this is what mini-gastric bypass is. See, apart from these surgical procedures, yes, we do in non-invasive procedures also. This is called gastric balloon. There are two types of gastric balloons available. Video please. This is a gastric balloon. Where nowadays we do it in two different types of procedures. Endoscopic gastric balloon. Through endoscopically, we keep a balloon inside the stomach, which again occupies the nearly 70 to 80% of the stomach. So it causes satiety for a person. So this balloon can be kept by endoscopically also. Nowadays swallowable balloon also has come. Within 8 minutes, a patient can swallow a pill which can convert into a balloon inside. So it again causes food restriction. But there is again durability of the balloon is there. Endoscopic balloons can be kept inside the stomach like 6 to 8 months alone. But swallowable balloon one can be kept only in the stomach like not more than 3 to 6 months. 3 to 4 months alone. After 4 months, it will come in the stools itself. It will just leak, the saline inside the balloon will get leaks and it will start coming out to the stools itself. But endoscopic balloon has to remove, again retrieve through endoscopically alone. And this procedure is called endoscopic sleeve gastroplasty. Through endoscopically, we take bites inside the stomach by reducing the stomach size of the stomach by taking the stitch over the greater curvature. This is called endoscopic sleeve gastroplasty. After all these minimally non-invasive procedures, patient can be discharged within half a day, not more than that. So the greater curvature size will be significantly reduced. So this procedure and this endoscopic interventions or non-invasive procedures not should be done more than BMI of 32.5 because it doesn't act for morbidly obese people. So nowadays is again 3D laparoscopic. So again robotic technologies, and nowadays or any abdominal surgeries through laparoscopic we can do any with single port surgeries. And what about diabetes resolution after metabolic surgery? See, this is how the metabolic diabetes resolution after bariatric surgery occurs. Since we are bypassing the small intestine and joining with the stomach pouch, the exclusion of the duodenum results in inhibition of putative signal that is responsible for insulin resistance or abnormal glycemic control. Reduction of amount of these putative anti-insulin factors would increase insulin action or secretion, thereby improving glucose homeostasis. This is what happens when a person are morbidly obese. What happens is the incretins will be secreting less, and the anti-incretin factors like leptin and other hormones will be secreting more, so the patient doesn't have satiety at all. So because of the iron gate hypothesis, because the rapid delivery of undigested food nutrition to the distal bowel upregulates the production of incretins and improves glucose homeostasis. So this was one study where the 500 of gastric bypass patient out of 500, 95% got diabetes got resolution, and out of 500, 92% of hypertension, cardiac function improvement 95, osteoarthritis 82, sleep apnea of 75, stress incontinence 87, GERD of 98, and cholesterol of 97, dyslipidemia of 97. See, overall quality of life, relief from all comorbidities, improved appearance, perception of well-being, social function, body self-image, self-confidence, ability to interact with others, increased time spent in recreational physical activities, enhanced productivity, increased economic opportunities, new employment, and more lucrative employment even. See, these are some photos of a patient that is before and post bariatric surgeries. She was 40 years, infertile, married for 15 years, PCOS, irregular cycles, diabetes, HbA1c of more 11. After this, BMI of 39.8. She was from Razipuram. She got operated, and she is right now IVF conceived with last 3 months. She is around 112 and she is 115, again married for 4 years, infertility, and after surgery she had a natural conception because her age is only 22 years and married for 4 years. And this boy was 27 years, weight of 136 kgs. She was 40 years, again BMI of 43, and she was again married for 20 years, infertility. She delivered just 2 months back. She is more than 2 years right now, post bariatric surgery. Her BMI is 32, psychologically depressed. She doesn't want to get married, and without losing her weight, we tried diet and physical activity for last 1.5 years before surgery. And after that there was again yo-yo phenomenon, and finally we need to go with surgery because her depression, at least her weight depression, has to go off. She got married and she is conceived right now, coming for follow-up. And she was around 110, she was 118, she was 36 years, 126, and she was 27 years, weight of 202 kgs. She is right now 93 kgs. An 18-year-old boy, weight of 168, 27 year 142, 40 years 140 kgs. After bariatric surgery, yes, he is into more of muscle building. His age is 33 years 138. Yeah, 50 years, weight of 100 kgs with incision hernia. Obesity, add some incision hernia also. So after bariatric surgery, after 1.5 years, we did abdominoplasty with incisional hernia repair. This is a team. She was 96 kgs, age 33 years, 42 years, weight 140 kgs. And these are the patients which we have operated in Gujarat for pediatric age group people. These people are like Prader-Willi syndrome or leptin gene positive syndrome. 11-year-old boy, weight of 127 kgs. 3.5-year-old kid, weight of 54 kgs. And again is a Cushing syndrome. And both couples, husband and wife, yes. And in the institute what we have worked, I was working in Gujarat, right, we had at least in one day we have operated on 22 cases. So what about complications? When we talk, yes sir, we talk about all these processes. What about the complications? The complications are like leak, bleeding and food intolerance and malabsorption. When it happens, it happens when it's a poor selection of the patient and procedure and lack of follow-up. How to prevent it? It should be a structured program. See, when the leak and bleeding happens, and we should have some good surgical skills, and because of laparoscopic and advanced surgical techniques, what we are practicing right now, the leak and bleeding can be detected intraoperatively and be corrected there itself. Food intolerance and malabsorption. Food intolerance, the patient has to be counseled before bariatric surgery. That patient has to eat food at proper times, no starvation, adequate hydration. Because if they don't eat food at proper times, the anastomotic area, if they have starvation, the gastric juices, that itself will not allow the anastomotic site to heal. So they will have a food intolerance. The malabsorption is, if we don't follow the guidelines of Indian guidelines, and if we started following the Western guidelines, because the loop length, whatever we bypass, if we bypass more than what patient needs, then patient is going to have malabsorption. So when it comes to all other studies, according to the complications, yes, in the 5 years rate, the GERD, insufficient weight loss and small bowel obstruction, internal hernia, severe drumping syndrome, like incisional hernia, other endoscopic, and more than morbidity for more than, when you compare the p-value, it is less than 1%. It is not even 1%. The complication rates of bariatric surgery, it is because that what we learned in day-to-day life, and because of our experience, it is very, very less, because we are practicing as per Indian guidelines alone. We doesn't follow Western guidelines nowadays. And when it comes to safety, again, when compared to all other procedures like cholecystectomy, like fundoplication, appendicectomy, colectomies, the bariatric surgery's mortality rate and other complication rates are very less, because we are going to do in a virgin abdomen. It is not a diseased abdomen, and it is just a primary stomach or jejunum what we are going to operate. So we are not going to have any mortality or any complication after this surgeries. Again, the bariatric surgeries, when mortality rate is very less when compared to other procedures, because other procedures patients come with the diseases. Here obesity alone, we need to treat the primary virgin abdomen, that's it. So when it comes to cure, yes, we must have seen this comedy in our old, this one was old movie. This comedian, this Daddy Balaji would ask Vivek comedian, sir, there are many diseases in my body. I need one tablet to cure all my diseases. But there is no as such one tablet like that. But there is one disease. If you don't have this disease, your diabetes will be cured. Hypertension, cholesterol, sleep apnea, fertility, depression, self-esteem, confidence, and increase your life with loved ones. That disease is called morbid obesity. We should treat the disease, and treatment should be multimodality approach. See, right now, the bariatric surgery guidelines, we don't do bariatric surgery if the patient follow these, if the patient doesn't lie under these criteria. Like BMI should be more than 35 without any obesity-related comorbidities, BMI more than 30 with the presence of type 2 diabetes or any obesity-related comorbidities, BMI of 27.5, BMI with uncontrolled diabetes, because the surgery, whatever we do, controls the diabetes, or if we follow it for more than 30 BMI, long-term cure or resolution of diabetes will be there. When it comes to a structured program, yes, a bariatric team should be like surgeon, anesthetist, pulmonologist, endocrinologist, dietitian, psychologist, physiotherapist, and a trained staff who can help obese people. Support group meeting, which matters a lot. One person who supports that obese people will motivate one more obese people that you are doing better, that do more great. So when it comes to, yes, obesity management, it is a team approach, and it treats the, when you treat obesity, it defines the ultimate quality of life. It is not going to be a cosmetic problem at all. So thank you so much. Thank you. So any more questions? Yes, we can ask in the last. It's end of this. Thank you so much.
Thank you, sir, for the wonderful speech.